Welcome to Clinical Conversations 109th podcast. It comes to you from Journal Watch. Go to the website at jwatch.org. I'm Joe Elia. It's November 19th, 2010. I'm joined by my Physicians First Watch colleague and co-host, Dr. Danielle Schurer. Hi, Danielle.
Hi.
Our interview this time is with Dr. Harlan Krumholz, editor-in-chief of Journal Watch Cardiology and also editor of CardioExchange, which is a medical social networking site. He's also professor of medicine at Yale. Dr. Krumholz spent the past several days observing the happenings at the American Heart Association meeting in Chicago, and we wanted to get his point of view for the benefit of practicing clinicians. Hi, Harlan. It's good.
Hey, how you doing, Joe? Hi, Danielle.
Hi.
It's good to have you back on Clinical Conversations. I think we talked about a year and a half ago about another paper that you had. But you had lots of writers from CardioExchange blogging from the Chicago meeting, including yourself.
Yeah, you know what I did a little bit. What we did this time was particularly to try to bring out some trainees, some fellows, cardiology fellows, and try to see how did they experience the meeting. So through sort of fresh eyes, you know, what's the meeting like to them? This year's meeting was, I think, quite a success. They told me that the attendance was up about 8%. It was in Chicago, and there was a lot of science around. I don't know. There's been, I guess, some early obituaries written on these large meetings, concerns that as our profession fragments, that people won't want to come to big meetings anymore, find them impersonal. But I must admit there was a bit of a buzz at this meeting. People seemed to enjoy it. Chicago's a good venue. So overall, it was good. The fellows, you know, they noticed funny things, but it was great to have them part of the CardioExchange community.
We wanted to ask you about a couple of studies that we covered in Physicians First Watch during the week, and one of them is this new drug. I think it's pronounced anacetrapib. It's got some wonderful effects, and I'll let Danielle take up the clinical aspects from here.
So a fairly novel lipid drug, and you know, to the naive eye, pretty impressive drops in LDL and increases in HDL. Where do you think this drug is going to be used? Like in what clinical conditions?
Well, you know, first of all, this is a very early safety study, so I think people who hear about it need to understand that we've gotten excited about drugs before that haven't panned out. We love seeing promising drugs that are being further evaluated and to see what happens. And there's a couple of interesting things about this drug. It's in the same class as torcetrapib, which was a drug that was being developed by Pfizer, for which there couldn't have been more enthusiasm. They thought this was going to be a $10 billion blockbuster. They actually pegged the future of the company on this drug.
Yeah.
It had also remarkable effects on reducing LDL and raising HDL, and they took it to trial, and in a large number of patients, they terminated early because of increased mortality and increased cardiovascular events. So that was a very sobering experience, and I think for many of us represented a very important juncture in thinking like, wow, should we really be taking at face value the modification of risk factors as being a proxy for what's going to happen to patient risk? That is, just because you improve someone's lab test, are you going to improve their outcomes? And, gee, in this case, it really didn't. So it didn't destroy the class because it was such a marked effect on lab tests. People still thought maybe we should try with another related compound that perhaps wouldn't have the adverse effects. So this represents anacetrapib is a relative. Roche also is testing a relative in a clinical trial. And what Merck did, I think, was very prudent, and I applaud them. I've sometimes been a critic when they've rushed drugs to market that are just based on lab tests, and also when they've not been as forthcoming about data. But in this case, I really applaud them. I love being able to be someone who cheers them. And in this case, they did a safety trial. It was small. It wasn't definitive. But in looking at about 1,600 patients, it had a good effect on the lab values. In fact, amazing effects. Mm-hmm. And no big risk came out. No big benefit either. But it was too small to tell. So everybody needs to hold back, recognize now we're going to take another 3-4 years to study this in a trial, which is the appropriate next step. And hallelujah, if this thing turns out to be as good as pegged, I'd really love that. But we need to know that it's really important to see what happens to patient risk when you treat them. Kudos to Merck for taking the very prudent steps, not trying to go to the FDA too early, but, you know, taking their time to really see what this drug is going to do.
Great. So sort of keep on our radar for for future
right.
studies.
So it got some good publicity here, but it's not. We're 4 or 5 years away from, if everything goes well, to getting this thing on market. But hey, could be something really great. Love to see it progress, and I hope it's as good as it builds.
All right. There's another one, the denervation of the kidneys in uncontrolled hypertension. As I was reading the study, somebody alluded to the fact that, a couple of generations ago, they were doing this surgically to control hypertension, and now there's this intravascular approach through the femoral artery. They use radiofrequency ablation. Did you have a reaction to that study, Harlan?
Yeah, I thought it was actually one of the more exciting presentations at the meeting. A little under the radar screen because it's a little unusual. It's one thing for people to sort of understand, well, here's a new drug and it really affects your lab tests and changes your lipid values. But it's this one's, people are kind of saying, what? Denervating the kidney percutaneously? They're kind of we're all still sort of wrapping our heads around it. There was a study in Lancet a little while ago, you may have covered it, where it was a pre-post design. And they did this, and it had amazing effects on blood pressure. But, everyone's a little reluctant to embrace a technique that's not studied in a randomized trial. And so, kind of everyone held back their enthusiasm, wanted to see what would happen in a trial. Well, here's the trial, and the drug is pretty effective. And, the procedure is very effective. And this is a percutaneous neck, so it's basically interventional cardiologists or interventional radiologists could do this procedure. As I understand it, it's not so difficult. It would be pretty easy to teach people to do. And it holds the prospect of taking people who have difficult to control blood pressure and, I don't want to say fixing it, but, treating it in a way that means that they're really going to not have to be taking drugs or as many drugs. And, sky can be the limit on this and very difficult to control hypertensive. So expect this to get a lot more attention and discussion. Question I have is, what are the steps to getting this into use? Because it's, as I said, it's not a drug, and this is a trial that would be expected to provide the kind of evidence you need. They don't have outcomes. It's not an outcomes trial. Mm-hmm. But in this case, I think people would accept lowering blood pressure without any adverse effects over the period of time they're studying is pretty good evidence. I think people want to try to replicate this, but I think it's very promising, and I wouldn't be surprised if it got a lot of attention.
Yeah, another thing that's sort of emerging is this rapid evolution of oral anticoagulants that are coming down the FDA pike. And the specific study presented at the AHA was the rivaroxaban, which is an oral 10A inhibitor, and comparing that to warfarin for stroke reduction and then the safety aspect of bleeding.
I'm really glad you said the name of it. I'm just learning to pronounce all these things. I don't know if our listeners are having a similar problem. I just want to say, yeah, that drug that they tested,
right.
That rivaroxaban and then dabigatran.
Yeah, I'd say dabigatran, but again, I'm not convinced I'm the gold standard for pronunciation of these either. But
I love dabigatran.
Dabigatran,
is that right?
or dabigatran. I don't know. And I'm sure they're going to come up with some fancy, easier to pronounce name, but I'm sure that our readers, one of the things that they are finding challenging is keeping them all straight. So these are thrombin inhibitors, direct thrombin inhibitors. And the thing is, if they remember their early medical school classes about the coagulation cascade, this is right down at the end. And the advantage of these medications is that you don't have to be checking the INRs, and they're not susceptible to dietary changes and should be a lot easier to use in these trials where, the trials are an unusual environment in the sense that, you have research nurses and you're ramping up and you want to try to compare drugs to good care, not bad care. Now, the problem is using warfarin, it's often bad care, not necessarily because of the docs, but you got to get people in, they've got to be, compliant, they've got to check their INR, they've got to eat consistently.
Right.
There's a lot of things to manage, and, in some countries, like the Netherlands, they've somehow figured out how to manage most of their people really well. In the U.S., it's variable, and depending on what system people are in and their own commitment, it can be difficult or easy to manage this. But in these trials, in general, the warfarin groups are well managed. So you're saying, how does this new drug compare with pretty well managed warfarin patients?
Mm-hmm.
And what we're seeing is most of these are non-inferiority studies. That is, what the question is it worse?
Is it good enough? Yeah.
Is it good enough? And then there is a strategy to test superiority, but generally what's happening is that these studies are showing non-inferiority. That is, that they seem to be a reasonable alternative, but they aren't better. Now, we know they're going to be more expensive. So how is that convenience and consistency going to feed in? How are we going to make these choices? The good news is that they do seem to provide an alternative. And for some patients, that's going to be quite in advance, those patients who are having trouble doing what they need to do to be successful on warfarin. How we're going to manage it other than that with a drug that may be $6 or $7 a day is going to be a question. But anyway, the trial Rocket AF, that's what was presented here. And the bottom line from it was it looks to be as good as warfarin. And in that case, what I mean by that is warfarin that's fairly well managed. So the big challenge here, and that's the sort of same message you got out of the European Cardiology Society meetings in the summer about dabigatran or dabigatran or however you want to say it. And so, there are going to be probably a slew of these coming out, and unless one shows itself to be dominant, then it's going to really, I think, challenge us to say, when are we going to use them? And are we going to offer them to everybody and let them choose, or, who, and what's going to be the cost for what return if, in the end, the clinical outcomes can be pretty much the same?
Right, so it remains to be seen sort of who gets a foothold here and if Coumadin will essentially become extinct in the management of AFib.
Yeah, and I sort of doubt it. It's very inexpensive, and for many people it works very well. It is a little more, it's going to be more inconvenient, but the question is, what's that worth to people? And who's going to bear the cost of the greater convenience? Certainly don't want to ration this stuff, but if it's not any better, then the profession and patients are all going to together be challenged to say, how are we going to use it? Another point I think it's really important is when a new drug starts being used, there is this extra risk of the unknown. That is, okay, we studied in these trials. Now when 1 million people take it, do we learn anything new about its safety? So there's at least some reason to hold back a little bit on these new drugs, as some people will be early adopters, but to kind of see and be sure that when it's used in actual practice, it's as good as it appeared to be in the trials. And because we always tend to learn a little bit more when it's being used in practice. And so for those people who, want to hold back, they're not losing anything, because if they can use warfarin appropriately, they're going to do just as well clinically, and they can wait and see what the final verdict is as these drugs get rolled out into general practice.
Harlan, there was one more, is the cardiac resynchronization function added to implantable ICDs in people. Now, I know that's been used in people with severe heart failure, but this trial was done in people with mild to moderate heart failure, and it seemed to benefit them. But the device that they're implanting is a bit more expensive than just an ICD. Do you see some advantage generally to using these devices?
Right. So another very important study, it says that patients with heart failure and diminished systolic function who aren't as symptomatic, can they benefit from, they have an ICD, they're indicated for an ICD, but would they be benefited by a higher line device that would help improve the synchrony of the heart and help the heart to basically pump more effectively because of the coordination of the squeeze? And so, we've had this question for a while, which is we've got evidence in more severely symptomatic people. What happens if you creep up towards people who are less symptomatic? And this trial showed benefit, and that was good. So it's going to expand the indications. The tricky part about this study, let me tell you, these devices are very difficult because, the kind of discussions we need to have with our patients, especially when we're talking about our older patients, 75, 80 years old, whether they should get these devices. They're not risk-free, but they may have an average benefit overall. And we're often dealing with people who aren't exactly like the people in the trial because of their comorbidity or because of their age and other factors. But, overall, good news that we have another tool, another alternative, a way to help people. But the thing I think for people who are listening to know that's tricky here is that these devices are for people who have some problem with their conduction system. And so, in general, they've been restricted to patients who have longer QRS intervals. And the inclusion criteria for the trials have varied a bit. The inclusion criteria for this trial was 120 milliseconds. So the upper end of normal is 120. So we're saying abnormal QRS duration, but you get just a little bit past 120, you're not very abnormal. But the interesting thing is, okay, when you're usually thinking about how do I apply the information from a trial to my practice, the first thing you might do is to say, how does the patient in front of me compare with the people who were enrolled in the trial? And the first thing you might do is look at the enrollment criteria. And then you might say, well, gee, this was effective, and this patient fits it by their ejection fraction, their symptoms, their heart failure, and their QRS duration. But then you look a little deeper into the trial, and you see, actually, people weren't enrolling people who just had a slightly abnormal QRS value. They were enrolling people, the average QRS in this trial was 150 milliseconds. So you have to be a little careful about the direct conclusion. Plus, the people who seem to benefit the most are people with left bundle branch block, and those who are, at the farther end of the spectrum on the QRS interval. So we're sort of struggling with this with regard to the indications. The FDA has tended to favor the idea that we're really, even though it's a subgroup, it's really the left bundle branch block patients that benefit here. And the profession is kind of going to have to grapple a little bit with this. But we have tended to think about the indication for this group, even though the entry criteria for the trial was broader, but thinking that the real benefit was being concentrated in those with left bundle branch block. So if you see a patient with heart failure, depressed systolic function, who has got a particularly left bundle branch block or longer QRS, this is the kind of patient who, if you're a general internist, you might want to have a cardiologist take a look at and just think about whether or not they might benefit. And I really urge you, this isn't something we should ever walk in the room and say, this is what you need. I think there should always be a discussion about this is something which you could benefit from, but it's not for decision. We need to discuss sort of the pros and cons, because it's always complicated, and the patient's preferences, values, and goals should be what's driving.
Okay, Harlan. One final paper, and it's about your paper. You presented a paper at the conference about remote telemonitoring of people in heart failure, and your group about 8 years ago had done a similar study and found that there was a benefit to this procedure of monitoring people, having them dial in using a touch-tone phone with their weight and blood pressure, etc. This time, you had a broader sample, a nationwide sample, and you didn't find a benefit. What did you learn from that?
Well, here's the deal. The patients with heart failure are being, after they've been hospitalized, are ending up back in the hospital with an alarming frequency. About 50% end up back at 6 months, about 1 in 5, 1 in 4 end up back within 30 days, and mortality rates are high. So the question is, are there non-pharmacologic approaches that might be beneficial? Can we manage them better? Can we respond more quickly to episodes of decompensation when their clinical condition worsens? Can we help doctors get more information to manage the patient? So, there's a variety of disease management strategies, a lot of being touted by private companies. Some of them, they all cost money, and everyone's rushing to this area. We did a study about 6 or 7 years ago at Yale that involved a nurse and some home visits and a whole variety of things. And it was a small study, and we reduced readmission rates by 44%. It was a great demonstration, but we were left sort of wondering what was the active ingredient here and what could really matter. Plus, it was a small study. Anytime you deal with small studies like this, you really need to validate them. So we tried to pull out and said, gee, what about monitoring these patients? And so as you suggested, there was this product where everyday patients could call into a number and answer some questions from an automated phone tree, and including their weight and some things about their symptoms, that would be transmitted back to their doctors and flagged if they answered questions in a way that suggested they were doing worse. And we followed these patients over 6 months, and we were really confident this thing's got to work, got to help. The doctors are more in touch with the patients. They're supposed to get in touch with them if there's any evidence of changing conditions. This is going to be rare and cheap. And then, lo and behold, we finished the study, and it's true, the patients did call in on average they called in a lot, and on average 21 times for a patient they had changing conditions that was worsening. The offices generally always called them back and tried to figure out what was going on. But when you looked at readmission or mortality, bupkis, nothing. No benefit at all, zero. So I have to say, we were wondering in our study, and this is published in the Journal of Medicine, if the listeners want to take a look. I think it's a really important study for showing that we can't just assume benefit, but we have to test these kind of interventions with the same sort of rigor and enthusiasm that we test drugs and devices, because we can end up spending a lot of money and going down a whole different line of pathways that aren't actually helping anyone. But we can be under the illusion they are because of the selection of which we sort of pick certain people to get them. And I can't tell you how many people were just so convinced it's going to work based on anecdotal experience.
Right.
But it didn't work. But the real quick thing is, we were followed by a German study that actually had even better adherence than ours and did a lot more stuff than we did, because they didn't just stick down to the calls and monitoring. I think best study of that bigger package. Ours is of the smaller package, and they found nothing also. So I think both together is just telling us we got a lot to learn. It's not as simple as fix.
Harlan, that's a great overview of the conference, and we want to thank you for your time with us today.
Oh, it's a pleasure. I hope it was helpful to the listeners.
Yeah, that was great. Thanks so much.
That's it for Conversation 109. Earlier podcasts are available at podcasts.jwatch.org. Clinical Conversations executive producer is Adore Yano. I'm Joe Elia, speaking for myself and Dr. Danielle Schurer. Thanks for listening.